In this video, we'll discuss about benign migratory glossitis. So, what is benign migratory glossitis? It is a pseudocystiform mucositis of dorsum of tongue. All right. So, the keyword here is mucositis, pseudocystiform mucositis in the dorsum of the tongue. So, now coming on to the other names. Now, in other names, it is also called as wandering rash. It is called as erythema migrans. It is basically a red lesion. So erythema migrans. Also, it is called as glossitis areata exfoliata. Tava. Okay. The very common name is geographic tongue. Now, why is it called as all these names? Now, what we usually see is this is the tongue. Okay, we have some deformated area present here, and what you see is there is lines. There are wide serpentinous lines. What are these? These are wide serpentinous, that is snake-like serpentinous lines, which resemble the continental lines. Continental lines, due to which we call it as geographic tongue, wandering rash, okay, as well as erythema migrans. Now, coming on to the etiology. Etiology is unknown, but it usually is a genetic trait. Also, it can occur because of stress or asthma or due to eczema or due to allergy. Now, coming on to the epidemiology. It is quite common these days, but usually it is seen in 1 to 2% of the population, and it is mostly seen in children and adults, and there is a female predilection. All right. Now, coming on to the clinical features. Now, in clinical features, as I told you before, what we will see is there will be multiple, irregular, well demarcated, smooth patchy areas, erythematous areas on dorsum of tongue. Now, there is one thing which is very characteristic. What you see is these, they heal centrally, okay, but they spread peripherally or centrifugally. Now, what is the significance of telling you this point? This point means that it can spread to a number of places. So basically, that's why it is called as erythema migrans. Now, it can spread that much that it can spread into the ventral surface of the tongue as well. All right. Now, what you will see is in this lesion, you will see that the filiform papillae, they are absent, but the fungiform papillae, they are present. But in the previous video where I talked about median rhomboid glossitis, both of them were absent, right? Now, if they're present, they're seen as red small points or dots projecting from the surface. Also, yeah. Now, what happens is if there is one lesion that is healing, what you will see is then a second lesion will occur on some other part. Okay, so basically it is not an ever ending disease or a situation. Now, however, it is painless, but there is always or there might be burning sensations of the tongue. Now, what are burning sensations of tongue called as? It is called as glossodynia. Now, it can also occur with association to the psoriasis or scrotal tongue. Now, what is psoriasis? We'll cover this in the skin chapter. Now, psoriasis is basically when there is a silvery fish-like scale which is usually present. Okay. Also, what is scrotal tongue? It is basically the fissure tongue. That is the plicator tongue. Okay. Now, coming on to the histopathology. For histopathology, just remember this diagram and you are done. Um, Quite bad at drawing, but I'll make you understand. So, first of all right. Yeah. So starting from here, what you will see is hyperparakeratosis. Okay. Then what we will see is Monroe's abscess. Now, what is Monroe's abscess? Now, this is also seen in one more pathology in skin. I think it is seen in pemphigus, I guess so. No, it is seen in um, I think erythema multiforme or scleroderma. Yeah, so we'll just confirm it later. So, what is basically Monroe's abscess? What happens is there is the accumulation. There's the accumulation of polymorphonuclear cells that leads to the Monroe's abscess. Then what you will see is these retin ridges. They will be thin and elongated retin ridges. Then you can also spot some candidal hyphae. Then over here what you will see is chronic inflammatory cell infiltrate, vascular ectasia. All right. Also, some CD4 lymphocyte cells. There is no ulceration till it is not associated with the Ritter's disease. Now, coming on to the differential diagnosis. In differential diagnosis, there is psoriasis. Yeah, the Monroe's abscess was present in lichen planus. Okay, that's why it is the differential diagnosis. Chronic, atrophic, or hyperplastic candidiasis. Now, in treatment, basically, there is no specific treatment. What we do is we give topical corticosteroids or we pertain to the antifungal medications and maintenance of the proper oral hygiene. Maintenance of proper oral hygiene. Now, there's one thing that I forgot to tell you, which you can also mention in case you get this question, just to lengthen up the answer. What we see is there are four types of benign migratory glossitis. Now, in type 1, what you see is it is a lesion which is confined to tongue, to both the surfaces of the tongue, and it has both the active and the remission stages which are present. All right. Now, in type 2, what happens is the same as type 1, but it can occur in any other part than tongue. Same as type 1, but any other part of oral cavity or of mouth. Now, in type 3, this is the most notorious type. What you see is there is nothing very characteristic. Okay, so it is not very typical. It is not typical. One is a fixed form and one is an abortive form. Now, in fixed form, what we see is it is in on the tongue and there is no migration. Few areas of tongue. And in abortive form, what you see is there is a yellowish white pattern or a patch that disappears before it resembles a granulation tissue. Disappears before it resembles a granulation tissue. Now, in type 4, what you see is there are no tongue lesions. So this covers the benign migratory glossitis or the geographic tongue. I hope you understood. And the very easy way not to confuse it with the median rhomboid glossitis is just by the name. Just remember the name well. It is migratory, so it is geographic or migrants. It is rhomboid, median, so it means that it is like this and it is present here, so that means that this is particularly candida. It is related to the papillary atrophy caused by candida. So this completes the lecture. Thanks for watching.